right, everybody, congratulations, you've made it through all of your terminology, and now we get to go into our actual physiological systems. So we'll start with our very first one, which is the integumentary system, which is all of your skin and hair and nails, a pretty straightforward system. We will start by looking at the anatomy and physiology of the integumentary system, and then we'll go into pathophysiology, some diseases that you see. We'll talk today about wound care, burns, bed sores, and then go into some autoimmune diseases that affect the skin, and then into cancer, and then we'll wrap up the lecture with an infectious disease of the skin that you have never seen and probably never heard of. These are our objectives for the lecture. If you are comfortable with these, you should do very nicely on the quiz on Wednesday. So let's talk about some functions of the skin. First and primary function of the skin is protection in a number of different things. Protection primarily against pathogens. So what is a pathogen? Let's break down that word really quick. So we have as our root word patho. Patho means disease. A pathologist studies disease. The pathologists are very, very busy right now. And then our suffix, gen. We get this suffix gen from the same place that we get the word genesis. What does genesis mean? It means creation or formation or beginning. So gen in this case means create. So a pathogen creates disease. So pathogens would be bacteria, viruses, fungus, parasite, protozoa, anything that could make you sick. And your skin is your body's first line of defense against these pathogens. The skin also protects you against damage, protects the tissues deeper in your body from damage. Think about how many times you accidentally bump yourself or run into the door frame on a daily basis. And it also controls what enters and exits the body, primarily in the way of water and salts and other things like that. This is especially important, we'll see when we start talking about burn victims. If you have a patient who has a bad burn, they have burned off their skin and now are susceptible to the water in their body evaporating because their skin isn't there to hold it in place. This is a big concern. Vitamin D production is another function of the skin. Vitamin D is found in meat and milk and eggs. It's absorbed in the small intestine into the bloodstream, and then it has to travel to the skin where it's activated by UV light. And UV light comes from the sun. So if you are sitting inside all day long playing, I don't know, Animal Crossing or making videos on TikTok, and you're never outside exposed to the sun, all of the vitamin D that you're eating, that you're consuming, is not going to get activated. Recommended that you get 15 to 20 to 30 minutes of sun a day, and that should be enough for your vitamin D production. Vitamin D is really important because you have to have this in order to get calcium out of your intestines. If you don't have enough vitamin D or any vitamin D, no matter how much calcium you consume, it's still not going to get from your intestines into your blood. Another function of the skin, excretion. You do lose small amounts of waste products in your sweat. Now, your skin does not have the ability to detoxify your body. We've probably all seen those foot baths on the ads on the daytime talk show or in the mall where you put your feet in the bath and it detoxifies your body. You cannot detoxify your body through your feet. Your skin does not have that ability. That's your liver's job, and he does a wonderful job of it. Body temperature regulation is another one, producing sweat when you're hot, shivering when you're cold. This little word piloerection right here, this refers to your little hairs standing up on end when you get goosebumps. That helps to trap air near your skin and keep you nice and warm. And then your skin is probably the biggest source of sensory information input that you have. You have so many nerve endings in your skin that are picking up on things like heat, cold, touch, pressure, vibration, both very light vibration and very deep vibration, picking up on tissue injury, which will lead to pain. You know most of what you know about the world around you through the sensations coming in through your skin. So let's look then at the anatomy of the skin. Your skin is part of your integumentary system. This also includes your hair and your nails, both of which we will look at in a little bit. The outermost layer of your skin is your epidermis. Go ahead, look at the back of your arm, look at your hand, look at the person sitting next to you if there is one. All the skin that you can see is epidermis. This is a very, very thin layer. It's only 4 to 5 little layers of cells, very thin. The deepest layer of the skin is called the stratum basale. And you've probably never heard of stratum basale before, but you may have heard of basal cell carcinoma. Possibly. If not, you will after today. Basal cell carcinoma is a skin cancer that arises from the stratum basale, that deepest layer in the epidermis. The stratum basale is what produces your new skin cells. It's constantly churning out new little cells, and as it's making new cells, the older cells are getting pushed up to the surface of your skin, and as those skin cells rise up towards the surface of your skin, they die. So again, look at the back of your hand, look at your arm. Everything that you can see there, all that skin that you can see, that's all dead. Take a minute and appreciate how much time and effort you spend making dead stuff look good. As those cells rise to the surface, they also fill with keratin. Keratin is a hard protein. We find it in nails, in hair. You find it in your dog's toenails. Horses' hooves are made of keratin. It's what gives your skin its protective quality. The stratum corneum is the outermost layer of the epidermis, the layer that you can see when you look at your skin. This word corneum right here, this refers to keratin. So this is the layer of the skin that has keratin. The stratum corneum, again, is a bunch of dead cells. They're constantly being shed off and replaced by cells lower down. You lose about 1 trillion skin cells every single day. Most of the dust in your house is actually dead skin cells. So think about that the next time you change the vacuum. Within your skin, in your layers of your skin, you have specialized little cells that make melanin. We call these guys melanocytes. What is melanin? Melano, what does that mean? Should recognize that from studying for the quiz. So melano means black or dark. Melanin is the pigment in your skin that gives your skin its color. It protects you against sunlight by absorbing UV light from the sun and keeps you from developing skin cancer. Now, the more that you're out in the sun and the more that you are exposed to UV light, the more melanin your little melanocytes will produce to absorb that increase in UV light. Everybody has the same number of melanocytes. If we were to sample people from all across the world, we'd all have the same number of melanocytes. The only difference is in how much melanin those melanocytes make. Some of them make a lot, they're very active. Some of them are not quite so active and they make just a little bit of melanin. So that's the epidermis. The layer of the skin beneath the dermis, or beneath the epidermis, is the dermis. And you can see here, the epidermis is named for the dermis. Our prefix epi right here means above or upon or over. So the epidermis is the layer of the skin above the dermis. The dermis, you sometimes hear people refer to as the true skin. That's not to say your epidermis is not important. If you didn't have it, you'd be very unhappy. The dermis is the place where all of the interesting stuff is found. The dermis is full of connective tissue that's holding the layers of the skin together. You find nerves, blood vessels, lymphatic vessels, hair follicles, oil glands, sweat glands. All of the interesting stuff in the skin is found in the dermis. The dermis nourishes the skin, it supports it, it keeps it provided with oxygen. Below the dermis then, we have our third layer of the skin, which is, you can refer to it with two different names, either the subcutaneous or hypodermis. And both hypo and sub mean beneath or below. So subcutaneous or hypodermis is the layer of the skin beneath the dermis. There's not a whole lot going on here. Lots of connective tissue holding the layers of the skin in place. Lots of fat, especially around bony parts of the body that need a little extra protection, like joints. Here's our cross section of the skin. You can see the three layers. You can see everything that's going on in here. You can see, first off, our topmost layer, the epidermis. And remember, it's very, very thin because it's only 4 or 5 cells thick. There's not a whole lot going on there. You can see over on the right, they've indicated for us the stratum corneum, the very top, and then the stratum basale down at the very bottom. And then compare that to what they have here for the dermis. Huge layer of skin. And look at everything that we find in there. We find blood vessels, there's arteries, there's nerves, there's a vein right there, pressure receptors, touch receptors, sweat glands, oil glands, hair follicles. This little erector pili muscle right here, this is the muscle that's going to pull that little hair upright when you get goosebumps and make that hair stand up on end. And then below the dermis, we find our hypodermis or subcutaneous. And you can see down there in that bottom layer, there's not a whole lot there. Larger arteries, larger veins, larger nerves, lots of subcutaneous fat as well. Now, practically speaking, knowing the layers of the skin is important when you go to give injections, and you guys will learn how to do all of these injections when you start practicing your skills. The most common form of injection, the one that you generally think of when you're giving an injection, is an intramuscular. If you've ever had a shot, think about if you had, for example, the flu shot last year, that's an intramuscular injection. They grab your elbow or grab your shoulder and kind of dart you. An intramuscular injection is going straight through all 3 layers of the skin down into the muscle underneath the skin. You do this, again, a lot of the time with shots. A subcutaneous injection is given below the epidermis and the dermis into the subcutaneous tissue. And this would be something that needs to absorb into the body over a longer period of time. It takes longer for subcutaneous stuff to get into the bloodstream. This would be something like insulin or heparin that you would give to a patient. An intravenous injection is going straight into the vein. Probably we've all had a blood draw. This is the same idea, except you're taking blood out. In an intravenous injection, you'll be putting something in, or maybe starting an IV. And then intradermal injections, these are not especially common, but if you have ever had a TB test, that's an intradermal injection. If you've not had a TB test, I'll see if I can find a decent video. They can be a little hard to find. In an intradermal injection, you're going right underneath the epidermis and injecting that little tuberculosis pathogen right under the skin. And then you're looking to see, does your patient 48 hours later develop any kind of response to that? Does their skin become kind of red and inflamed? Or does their skin stay normal? And that's your indication of whether or not that patient has had or been exposed to tuberculosis. So other stuff that we find in the skin, sudoriferous glands and sebaceous glands. Sudoriferous glands are your sweat glands, and I would know that word, sudoriferous, for your quiz. Sudoriferous glands make sweat. Sweat evaporates off the body and helps you cool down when you're hot. Sebaceous glands make sebum. And in both sebaceous and sebum, we see this little root word here, sebo, which means oil or oily. Anytime you see that S-E-B-O, that's referring to oil. The sebum that's made by your sebaceous glands lubricates your hair and your skin, keeps you from drying out, which is good. You know that if you wash your hands a lot, or if you're in water a lot, that will wash off that oil, and then your skin will get really, really dry. But sebum does more than just that. If I were to take your pen or your pencil and coat it in oil and then hand it back to you, what's going to happen to your pencil? It's going to get really slippery. It's going to be hard for you to hold on to. You're probably going to drop it. And the same is true of you. If we coat you in oil, you become very slippery and kind of hard to hold onto. And if I'm a little bacteria that's trying to stick onto you and colonize you and make you sick, and you're covered in oil, I might just slide right off instead of colonizing you. So that's an extra benefit to being coated in sebum. Other associated stuff, hair is non-living, just like your skin. When it's developing deep in the follicle of your scalp, it is alive. When it leaves your scalp, the hair that you can see and touch, that is all dead. Your hair is mostly made of keratin, again, the same protein that you see in the skin, and it develops from deep within that dermis. Your hair serves as protection, also as a source of sensory input. When stuff brushes your hair or moves your hair, that tells you what's going on around you. For a really extreme example, think of the whiskers on your cat or your dog. Your nails are also not alive, also mostly made up of keratin, and these develop from the little lunella at the very end, that tiny pale half moon at the very end of your nail. These serve as protection for the tiny little bones in your fingertip and your toe tip. Those bones are very, very small, and if you didn't have your nail, it would not take a lot of pressure to break those bones in your fingertip and toe tip. Having the nail there distributes pressure across the whole fingertip so that you're not putting direct pressure on that very small bone. These are a bunch of combining forms that refer to the skin. I'm not going to go over them because you don't want to listen to me read them all off. These will be very, very helpful while you're working on your homework. I would come back and visit those. I will say there are two that you should know definitely for the quiz. And those are tricho and onycho. Make sure that you know those for the quiz. Some key terms here. These will also be very helpful while you're preparing for the quiz. Again, I'm not going to read them all out because you don't want to listen to that. If you have questions about any of our key terms on here, definitely shoot me an email. So let's go into some clinical stuff with the skin. Study of the skin and diseases of the skin is dermatology. Hopefully you recognize that suffix logi, which means study of something. In every physical examination, you should be looking at the patient's skin, hair, and nails, especially the skin that they can't see, the skin on the back, for example. Look for any changes in color, any lesions, if the skin feels rougher or more tender, or is weeping, or is very, very dry, or is hard or cold. Any abnormalities with the skin should be noted. We're going to start talking about wounds and wound care. So wounds can be caused by two different things. They can be caused either by trauma or by surgery. Between the two of them, which do you think has better outcomes? Let's imagine we have two patients. We have one patient who has come in to have their appendix taken out. He's just going in for a routine appendectomy. And we have another patient, they just brought him in. He was in a really bad car accident, got all smacked up. They both have some pretty significant wounds. Which one do you think might have poorer outcomes, or which one just might be more concerning? So the one who has wounds with trauma, this is going to be the one that we're a little more concerned about. Think about cutting into somebody in a surgery suite, in an operating room. Usually it's very, very sterile. Usually you're only making, one incision or two, and you know exactly where you're going. And then that wound gets sewed back up right away. Everything's very, very clean. As opposed to your patient who got beat up out on the highway, where it's not very sterile, where he's got cuts all over himself. You expect to see more complications and more issues with the wound caused by trauma. These complications can include things like infection, which is always a big concern, probably your number one concern when you're dealing with wound care. It can include hemorrhage, your patient bleeding out, especially early in wound care. Dehiscence is wound layers coming apart. That's what we see up here in our patient. Their sutures have split open, and then because of that, we see this evisceration. Their organs are protruding out through the wound. That's bad. That needs to be addressed and taken care of right now. As your patient's wound heals, you'll see drainage of fluid from that wound. We call this exudate. That prefix EX in exudate, this is the same prefix where we get our word exit from. So exudate is fluid that's leaving the body. Exudate can be, should be clear, maybe kind of yellowish or straw colored, but it should be clear. If it has blood in it, that's not uncommon early in wound care. If it is kind of creamy yellow or creamy white, that means it has pus, and that's not good because that means that our patient has an infection in that wound. So good wound healing involves, first and foremost, making sure that that wound is nice and clean, making sure that your patient is not getting an infection in there. Good circulation is important. There's some parts of the body that just naturally don't have especially good circulation. One of those is the feet and the lower legs. Your patient gets a big wound or a bad cut on their feet. It may take them a lot longer to heal. Another one would be your scalp. Your scalp takes a while to heal because your scalp doesn't have especially good blood flow either. Making sure that your patient is just in good overall health is also important. If your patient is in the throes of fighting off cancer, it's probably going to take a while for that wound to heal, more so than if they were healthy. Cicatrization is a word that refers to a scar formation. A scar is a cicatrix, which I believe is the same in Spanish. I know it's the same in French, cicatrice. So things that we can do to encourage healing in a wound, especially a big wound. Vacuum-assisted closure is a very common means of keeping the edges of a wound close together, especially a big one, to make sure that it heals properly. I'll show you an example of that in a little bit. If you have a patient whose wound has started to scab over, or the edges of the wound have started to scab over, and you need to encourage growth of new tissue to keep that wound healing, you may have to go in for debridement. And in that you would scrub or use enzymes to get rid of dead or damaged tissue in that wound to encourage it to make new healthy tissue. You may also have to do escharotomy, which is removal of scar tissue, again, to promote the production of healthy new tissue in that wound. Okay, so here's our patient, our poor patient who got all smacked up on the interstate, and they brought him into your ER. And they moved him up to ICU, and now you need to help take care of him. And he's got this giant gaping wound over here on his calf. Now, if we were to leave that as it is, we take good care of it, we keep it covered with dressings, we change it regularly, we make sure he's on antibiotics, but if that was all we were to do with it, would it heal eventually? It would come together eventually, but it would be covered in scar tissue, which is not quite as flexible as your skin, so he'd probably lose some range of motion in that leg. And in addition to that, that's going to take a really long time to heal. So because we don't want to wait that long, there are a few options that we can do. And one is vacuum-assisted closure device, which is what this is right here. So you're going to go get a piece of nonstick foam. That's what that gray stuff is. And you're going to cut it, you can see, to the exact shape of the wound. And then stick it on top of the wound. And then you're going to cover the whole thing, the wound, the foam, the leg, with this stuff here, which is essentially glorified saran wrap. It's not real saran wrap. They did not send the MA to King Soopers, but it basically looks and acts like saran wrap. You're going to wrap that all over the leg, all over the foam, until the whole thing is sealed off. And then you're going to take your scissors and punch a tiny little hole in the saran wrap. And then over that hole, you're going to affix your little vacuum. And when that vacuum turns on, it's going to suck all of the air out of that foam and out of the wound, and it's going to suck the edges of the wound closer together. And this encourages blood flow to that area. It promotes healing. It will cut down significantly on the time that it takes for that wound to heal. This is a very, very revolutionary discovery in wound care and wound healing. This has cut down significantly on healing time, on infections, and on complications. Now, they do make little portable vacuum-assisted closure devices that you could stick on top of that leg and kind of saran wrap onto the leg and send them home with it. This will need to be changed every 48 hours or so, but he can, in theory, keep that little vacuum on there, as long as it takes until that wound heals. Other things that we can do to promote healing for the slightly more gory among you, we can do skin grafting. Usually you see this for either very deep wounds or very, very broad wounds. Our patient in the last slide might have been a candidate for skin graft. When you do skin grafting, you're usually taking either the epidermis or the dermis. Sometimes you take both. A full thickness skin graft, you're taking both of them, the epidermis and the dermis. In a split thickness skin graft, you're just taking the dermis. We do this procedure with a dermatotome, which is this thing right here. Almost looks like a glorified cheese slicer. And it works the same way. For the more bloodthirsty among you, I will have a nice video of a dermatome in action that I will post. You do not have to watch it if you do not want to. It is a little intense, but it's kind of interesting to see it in action. Okay, let's move then from wound care into burns. Burns can be caused by a whole bunch of different things. Usually when you think of a burn, you think about, something hot. You accidentally bump your hand against the heating element in the stove, or you spill the hot coffee all over your arms, whatever it may be. But there's other things that can cause burns that may change the way that you look at or treat your patient. For example, scalding, being exposed to lots of really hot steam, that will definitely burn your skin. Electrical malfunctions, so maybe you're working on the wiring in your house and something goes wrong and you get zapped. That would do it. Coming in contact with harmful chemicals, like the battery acid in your car, for example, that will result in skin burns. And then abrasion as well, while it's not technically a burn, will affect your skin, very similar to burns. So when you have a patient who comes in with a burn, you're going to want to look at a couple of things. First, the depth of the damage. This is if you've heard of degree of a burn, 1st degree, 2nd degree, 3rd degree. That's what we're talking about there. And then also, what percentage of the body surface area was affected by the burn? How much of your patient's body has been burned? So a superficial burn is what we would call a 1st degree burn. And we've all had 1st degree burns. You get a little bit of a sunburn, or you accidentally bump your hand against the heating element on the stove, and your skin is red and it hurts for a couple of days, and then it goes away and you're done. That's because a superficial burn involves just the epidermis, which is why they call it a 1st degree burn. It involves just the first layer of the skin. A partial thickness burn can involve either part of or all of the dermis, and a partial thickness burn is a 2nd degree burn. And the hallmark of a 2nd degree burn, how you know you have a 2nd degree burn, is that you see blisters. Blisters are are your classic sign of second-degree burn. If you have a very severe second-degree burn that goes all the way through the dermis, your patient may have less pain than someone with a not quite as severe second-degree burn, because they've burned away their nerve endings, so they can't really feel that pain anymore. Now, when those nerve endings start to grow back, they will most definitely feel the pain of that burn, very much so. A full thickness burn is what we would call a third-degree burn. Here we've burned through the epidermis, the dermis, down into the hypodermis, the subcutaneous layer. Third-degree burns can look different depending on the patient, depending on what burned them. Sometimes the skin will look kind of broken and dry and pale. Sometimes it will look sort of black and charred. With a third-degree burn, you may be looking at the possibility of losing, digits, losing fingers or toes, or losing a limb because of the damage to the tissue and the damage to the skin. This also may require a skin graft if your patient has a really, really large third-degree burn. So that's depth of the burn. Now let's look at body surface area. And we do this using the rule of nines, or London-Browder. Both of these divide the surface of your body into percentages to make it easy to then add those totals up and see how much of the body has actually been burned. Rule of nines is pretty simple. In rule of nines, each part of the body is worth 9% of the body. So one whole arm, for example, front and back, would be worth 9% of the body. We divide the torso in half, so the top is worth 9%, the bottom is worth 9%, your genitalia is worth 1%, don't get burned there. The top of the back is worth 9%, the bottom of the back is 9%, the front of each leg is 9%, the back of each leg is 9%, your head and neck total are 9%. So then how this works is, let's say you're in the ER and paramedics call and they're bringing in a patient. It's 4th of July. He got drunk and played with fireworks, and his last words were, "Here, hold my beer and watch this." So the paramedics bring in your patient, and your patient has been pretty badly burned all up and down the front and back of that right arm there, burned all the way up, and the front of his right leg. It's okay, his buddy said he looked really cool when it happened, so we're good. And the nurse gives you a little rule of nines sheet and says, go out there and see how much of his body surface area has been burned. Well, you know that the whole arm, front and back, is 9%, plus the front of the leg, front of the whole leg, is 9%. So 9% plus 9%. You guys didn't think you were going to get into math this soon, did you? Is 18%. So our patient's been burned over 18% of his body, almost a fifth of his body. That's a lot. Don't get drunk and play with fireworks. So that is how rule of nines works. London-Browder is very similar. It's a little more specific, breaks the body up into even more specific percentages to allow you to be more detailed as you're going through that. So burn treatment. We got, we'll call him Bubba, into the burn unit after his incident with the beer and the fireworks. And now you're taking care of Bubba. What do you think is the first thing that you want to worry about while you're taking care of this patient who came in with pretty severe burns? Almost a fifth of his body is burned. What's the first thing you want to focus on? When I ask this to my class, usually they talk about things like wound care, making sure that he doesn't get an infection, making sure that he has good pain medication, getting him fluids back in. And those are all really important. But maybe the most important for your burn care is actually respiratory. The lungs see some pretty significant changes when your patient gets burned, and they develop lots of issues, sometimes pulmonary edema, where you get buildup of fluid in the lungs due to your patient's loss of fluid. In addition to that, think about what your patient was probably exposed to that landed them in the burn unit. Did they get burned with really, really hot steam? If so, they breathed that into their lungs, and that could have scarred their trachea and their lungs. Did they get burned because they were exposed to chemicals that burned their skin? There's a lot that can cause that. Maybe they were pulled out of a fire in a burning building and they inhaled a lot of smoke particles. So making sure that your patient is breathing properly, checking their lungs is definitely step number one for taking care of burns. After that, making sure that your patient has fluids and lots of fluids, because remember, your skin is your body's first line of defense against disease and against fluid loss. So your patient's going to lose a lot of fluid because they burned off all their skin. They'll need to get that back. Taking care of wounds, pain control, obviously that's going to be very unpleasant. And then looking for complications, which can go from the possibility of infection down even to PTSD. If you did something that landed you in the burn unit, it was probably really scary and probably kind of traumatic. Okay, going from burns now into pressure ulcers or decubitus ulcers. A pressure ulcer is a necrotic lesion on the skin. And that word necrosis up here, hopefully necro rings a bell. Necro refers to something that's dead. It refers to death. If you've practiced necromancy, you practice communication with the dead. I tried to explain this to a class once and they had no idea what necromancy was, but for concerning reasons, they all knew what necrophilia was. So that is also an example of dead, doing unspeakable things with the dead. A pressure ulcer is also called a bed sore or a decubitus ulcer. And this usually happens on the skin where you see skin covering bony parts of the body. The sacrum is very, very common. The sacrum is the lower spine down in between your hips, down in your very low back. You see it sometimes over the heel, the elbow, over the outside of the hip as well. So what happens when your patient develops a pressure ulcer? Essentially, it means they've been sitting on that part of the skin for too long. And as they sit on that part of the skin or lie on that part of the skin, that cuts off blood supply to the skin. And if something does not have blood, it dies. And that's what happens with the skin in a pressure ulcer. You've cut off blood supply to that area. The skin will eventually die off and then slough off. And then you're left with what we see here in this picture. All of the tissue underneath is exposed. There's a lot that will contribute to pressure ulcer development. Generally speaking, you see this in patients who just cannot move themselves for whatever reason. They're hospitalized or they're in a wheelchair or, put in a coma. Probably this is a big concern with our COVID-19 patients. This will first show up just as general redness of the skin and can go from a little red patch on the skin to an actual ulcer in a matter of hours. These can crop up very, very fast. If you ignore a pressure ulcer, it can eventually eat through the skin, through the muscle, into the bone, and then it gets really, really tricky to treat. These take a very long time to heal. This might be a good option for a vacuum-assisted closure device, and they're also incredibly painful. So the best treatment then for a pressure ulcer is prevention. There are lots of pads that will help to even pressure across the skin. You can also use what we see here, little pads that will cover bony areas of the skin to keep from getting excess pressure on the skin. Sheepskins are supposed to be very good for this, for bringing air underneath the skin. Making sure the skin is clean, making sure it's dry, making sure your patient is not lying on their back or on their side all day long. And then good nutrition is also important, making sure that they have lots of B vitamins, lots of healthy fats that will help promote good skin health. Okay, going from our wounds, let's talk about some skin conditions and autoimmune diseases. Dermatitis is inflammation of the skin. Hopefully you recognize that suffix itis, which means inflammation. So dermatitis is inflammation of the skin. The example that they give us here is atopic dermatitis or eczema. There are lots of kinds of dermatitis. This is just a very, very common one. That word atopic, anytime you see atopic or atopy, these are referring to allergies. So atopic dermatitis is inflammation of the skin due to some kind of allergy. Usually it's a chronic inflammation. This is not like exposure to poison ivy that's very acute. You get dermatitis for a day and then it goes away. This is, dermatitis that stays for days, maybe weeks, maybe months. The cause of eczema is not well known. We know that if your patient is exposed to, whatever they're allergic to, that will make it worse. Infection of the skin can make it worse. When you get really strong temperature extremes or humidity extremes, going from very hot to very cold or very humid to very dry or vice versa, that will exacerbate dermatitis. And then skin irritants, which can be anything from fragrances, dyes that you see in soaps or shampoos or detergents or laundry soap, that can make dermatitis worse. There are other forms of dermatitis. Seborrheic dermatitis is what we call cradle cap or dandruff. Cradle cap in babies, dandruff in humans. Contact dermatitis is what you usually think of when you think of dermatitis. This is you got into the poison ivy and now your skin is inflamed and itchy and weepy and red. Stasis dermatitis occurs when you have a patient that doesn't have really good circulation and they get buildup of fluid down in the feet and the lower legs, and you can see that kind of thick, reddish, cracked skin in that patient on the right there. All right, let's look at some autoimmune disorders then. A lot of autoimmune disorders that affect the skin. Before we jump into that, let's talk real quickly about what on earth is an autoimmune disorder. So, what is your immune system? What does it do? What's its purpose? Hopefully you're thinking about stuff like viruses, bacteria. It's there to keep you safe and keep you protected against pathogens. It's there to attack bacteria and kill them off. And that's what its job is. In an autoimmune disorder, however, the body starts attacking, or the immune system starts attacking the body. As if the body itself was a bacteria or was a virus or a parasite. It recognizes the body instead as foreign. What causes autoimmune disorders? Why does the immune system suddenly recognize the body as foreign? We don't know. We do know that women tend to have autoimmune disorders more than men. There's a lot of research going into this because autoimmune disorders kind of seem to be on the rise right now. Let's look at a few of them that you see affecting the skin. One is psoriasis. This is fairly common. Psoriasis happens when you get increased growth of the cells of the epidermis. You're making lots and lots and lots of epidermal cells, but they're not sloughing off at the same rate. So you get this buildup of epidermis on the top of the skin, which leads to these big reddish plaques. This is what erythematose means. You recognize erythro in there, hopefully. Erythro means red. So big red plaques with these silvery scales on them. You can see that really well in the picture on the right. Again, the cause of autoimmune disorders just in general is not well understood. There does seem to be a little bit of an inheritance pattern with psoriasis. It does seem to run in families, and that's true about a number of autoimmune disorders. Treatment for psoriasis, topical corticosteroids will decrease the amount of epidermis that's being made. Being exposed to UV light can also be very helpful for slowing down psoriasis. If your patient is not responding well to the corticosteroids, or if their psoriasis is just really, really strong, you may look into medications that suppress or turn down the immune system. Obviously, these come with their challenges, because if I'm giving my patient a drug that's going to turn off or turn down their immune system, what's going to happen to them? they're going to see this increased risk of disease if we shut off their immune system. They're going to be much more likely to catch diseases, and it's going to be much harder for them to fight those diseases off. And in fact, we do see that with immunosuppressant medication. We will talk about an example of that in a little bit that we see in patients who have to be on immunosuppressant drugs. Pemphigus is another autoimmune disorder. Pemphigus, a classic sign of pemphigus is blisters. You see separation of the epidermis from the dermis underneath, and that's what leads to these great big blisters. And then when these blisters rupture, that exposes the tissue underneath the skin and makes it susceptible to infection. And then also you're losing fluid out of those blisters that have ruptured. This will kill your patient unless you put them on some really heavy-duty immunosuppressant medications because their skin will just slough off of their body. You can imagine looking at those blisters on the back there. That is incredibly painful and incredibly unpleasant. Lupus erythematosus is a fairly common autoimmune disease most people have heard of. If any of you saw that picture of Selena Gomez in the hospital bed next to her bestie getting a new kidney, find you a best friend who will give you a kidney when you need one. Lupus can affect either the skin or it can be systemic. Discoid lupus affects just the skin. Systemic lupus, which I think is more common, affects the whole body. Systemic just refers to the whole body. Lupus is an autoimmune disease of connective tissue, and you find connective tissue all over everywhere, your skin, your organs. So there's not a lot that isn't affected by lupus. When we talk specifically about lupus and the skin, what we're looking at is this kind of what they call a butterfly rash right here across the cheeks and across the nose. You also call it kind of a wolf rash as well because it looks a little like the pattern on a wolf's face. That's where we get the name lupus. This rash tends to be kind of reddish, kind of purple. It gets worse when your patient is exposed to UV light. Patients with lupus tend to have cycles. They'll have a time when the lupus isn't so bad, and then they'll have a flare-up and it'll get really bad, and that rash will be very pronounced, and then that will go away, and they won't have quite as much trouble for a while. Scleroderma is thickening of the skin due to excess collagen production. Our root word in here, sclero, refers to something that's abnormally hard or thick or tight. Our kind of classic hallmark sign of scleroderma is these white lines that you see along the knuckles here. That's caused by that excess production of collagen that's starting to cause the epidermis and the dermis to separate. Your early sign of scleroderma is Raynaud disease. Raynaud disease occurs when your patient gets really, really sensitive to cold objects. So they go to pick up, say, an ice cube out of the freezer and their hand goes numb. That's Raynaud disease, and that can be an early sign your patient's going to develop scleroderma later in life. Albinism is not an autoimmune disorder. It is a genetic condition, but I tend to get a lot of questions about it from my students, so let's talk about it now. In albinism, your patient's melanocytes, either they don't make any melanin or they make just a tiny, tiny, tiny bit of melanin. And that is what leads to this very pale skin, almost white hair that you see in your patient with albinism. The most common kind of albinism is called oculocutaneous albinism. What does oculo mean here? Oculo refers to the eyes. So oculocutaneous albinism is albinism that affects both the skin and the eyes. This is an autosomal recessive disorder, and we'll talk a little bit about what that means. And it's very, 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 very rare. You'd have to get together between 17,000 to 20,000 people in the US to find one person who has albinism. So you may never see a patient who has albinism. Your patient with albinism will have very pale skin, and they won't be able to tan because they don't make any melanin, which means that they're really susceptible to sunburns and incredibly susceptible to skin cancer. So when your patient with albinism comes in, they will come in covered from head to toe, long sleeves, long pants, hat, sunglasses, slathered in sunscreen. trying to keep from burning underneath the sun. Excuse me. Usually the hair is white or very, very pale. The eyes are usually very light blue. And it's very common to see eye disorders in your patient with albinism. Photosensitivity means that they're very, very sensitive to light. They probably have to wear sunglasses indoors. Nystagmus are just random involuntary eye movements, and then reduced clarity as well. It's very common for patients with albinism to be legally blind because their eyesight is just that bad. So what do we mean by autosomal recessive? Autosomal just simply means that this gene does not show up on either the X or Y chromosome. Recessive means that you have to have 2 copies to be affected. In this case, to have albinism. There are some conditions in which you only need 1 copy of a gene to have the disease, whatever the disease is. For albinism, you have to have 2. So all of you could have 1 copy of the gene for albinism and not know that. And that would make you a carrier. If you have 1 copy of the gene and you don't show the trait, you are a carrier. So the only way you would figure that out is if you were really curious and went in and got genetic tested, or in the case of our couple up here, if you hook up with another person who is carrying the gene for albinism and you start having kids. There's a 1 in 4 chance, so 25% chance, that both of your genes for albinism will go to one of your children, and that child will have albinism. 50% chance that one of your kids will get just 1 copy of the gene, and then they'll be a carrier as well. They won't have albinism. And a 25% chance that your kid will not get either copy of the gene, and they won't be affected by albinism. So this is why we tend to see albinism in a kid, but not in their parents. We might see it in their grandparents or their great-grandparents. Okay, last of our big topics for this lecture, and that is skin cancer. This is the most common form of cancer that you find in people. 1 in 5 Americans, it estimated, will contract skin cancer in their lifetime. So think about you and think about, I don't know, your 4 best friends or your 4 enemies, depending on who you like the less. One of the 5 of you is going to get skin cancer at some point in their life. Now, the good news is most of our skin cancers are pretty benign and pretty easy to treat. Rates of skin cancer are increasing in the US just because we like being outside in the sun a lot. Though there is some interesting research that's suggesting maybe some of the chemicals in your sunscreen might also be contributing to that. So there's kind of a move back to our general mineral sunscreen, so titanium dioxide or zinc oxide. We'll look at a couple of very common types of skin cancer. We'll look at a not quite so common but very lethal type of skin cancer. And then we'll look at a very, very rare type of skin cancer that you probably never heard of. Before we jump into that, though, I want to talk a little bit about epidemiology. And hopefully this will give you a nice idea of where to go with your paper. So this data is taken from the CDC, and this is showing rates of skin cancer broken down by sex and by race and ethnicity. So you see men over here on the left, women over here on the right. This little dark green line here for both men and women, this is our overall amount of skin cancer. I know that this is a little old. This data goes from 99 to 2010. I'm having trouble finding the equivalent with newer data. But the trends that we see here, the principles that we see here are still pretty much the same. So just looking at these slides, at these 2 graphs, what really stands out? What's the first thing you notice? Hopefully it's that men have a whole lot more skin cancer than women. If we look at 1990, we had in men overall about 20 cases of skin cancer per 100,000 men. In women, we had, looks like about 11 or 12 cases of skin cancer per 100,000 women. So men have almost double the amount of skin cancer as women. Good heavens, it's a lot of cancer. Why? Why do men have so much more, almost twice as much skin cancer compared to women? Think about what men frequently do as an occupation. Think about the last time that you drove past that construction site on I-25. Who was out there working on that construction site? Probably some dude. Yeah, because men tend to have the more outdoor jobs, right? Construction, labor, road work, working on the farm, trucking even. So tend to be more exposed to the sun. And think also, what do women tend to wear that usually has at least a little bit of sun protection factor? There's probably a little bit of SPF protection in your makeup, in your foundation. No guy, Bubba is not getting ready for his long, hard day on the road construction site by working on his contouring. So men tend to work outside more. They tend to wear less sunscreen. Other things that stand out about this chart, are rates of skin cancer increasing or decreasing? In men, they're definitely increasing. We put a line of best fit through there. That's a pretty sharp increase. Not quite as much in women, but it is increasing as well. So rates are definitely going up. And then one other thing that you should notice kind of right away when looking at these charts. Look at the breakdown racially. Up here on the top, we've got the yellow is white, and then down here green is Alaska Native, American Indian Alaska Native. The purple is Hispanic. The blue is Asian Pacific Islander, and the red is Black. So who's getting the most skin cancer? All the white people. Why? As my last class post succinctly put it, because they white. Yeah, because they have less melanin in their skin, and less melanin means they're exposed to more UV light, and exposure to more UV light means you're going to burn more easily. So your kind of classic skin cancer case will be a white man. Now, that is not to say that we don't see skin cancer in these lower populations here. We do. And there is some evidence that skin cancer in those races may be overlooked because it can be hard to see skin cancer on darker skin. It looks different on darker skin. And you will see as we go through all of our talk about skin cancer in this, all the pictures that I have for you are skin cancer on very light skin. So that is a concern. All right, first of our skin cancer types is basal cell carcinoma. And this, if you remember, arises from the basal cell layer, or the stratum basale, the very deepest layer of the epidermis. This is the most common form of skin cancer. 75% of all skin cancers are basal cell carcinoma. It usually shows up on places in the skin where you're exposed to sunlight, which is nice. That means that it's going to show up on a place of your skin, or a place on your skin that you hopefully see fairly often. So places exposed to sunlight, this would be something like your arms, your hands, your face, your neck, your chest, maybe the tops of your feet. You're not going to see basal cell carcinoma on your left butt cheek, unless you're exposing that to sunlight a lot, in which case please stop. So you'll see this in areas that you notice on a regular basis, which is good. You'll catch it quickly. And usually it shows up like this little smooth papule. Sometimes with it, you see in this picture, it almost looks like it has a little scab over it. And that's often what will bring your patient into the dermatologist. I have this scab that keeps falling off and coming back and falling off and coming back, and it's been about 7 weeks and it still hasn't healed and I don't know what's going on. And that will be the suggestion to your doctor. Maybe we need to look at the possibility of skin cancer. We should cut that out and send it to pathology. If you do have basal cell carcinoma, that's what they'll do. They'll cut that little cancer out, send it to pathology to make sure they got all of it. And then generally speaking, that's it. This doesn't tend to spread throughout the body. You see it very quickly. your outcome for basal cell carcinoma is really, really good. Second most common form of skin cancer is squamous cell carcinoma. Also arrives from the epithelium, also derived in places that are exposed to sunlight. This one looks a little more red than the other one, but you see again that scab right there. And again, that's what will bring your patient into the dermatologist, the scab that keeps falling off and coming back and falling off and coming back. This tends to not metastasize. Metastasize just means cancer has started to spread through the body, going from where it originated to somewhere new in the body. So it tends not to metastasize, and usually if you get it removed right away, you should be just fine. Very good outcome for squamous cell carcinoma as well. Now, melanoma is a very rare skin cancer type. This is less than 1% of all of your skin cancers, but if you died from skin cancer, you died from melanoma. One person dies from melanoma every hour. So in the time that it's taken me to record this lecture, one person has died from melanoma. That's a lot. Melanoma originates in melanocytes. You see this often in a mole that maybe has mutated and become cancerous. The reason that melanoma is so deadly is because melanoma can spread very easily. It can metastasize easily. For a cancer to be able to metastasize, it needs to get to a certain size, and it needs to have certain genes turn on, if you will, in order for it to spread throughout the body. Melanoma is born with all those genes turned on. It doesn't need to get really big before it can start to spread through the body. That's one of the reasons why it's so lethal, because before you notice it, it's starting to make its way all throughout your system. If you catch the melanoma very early and you remove it, that's an excellent sign. If you don't, then you might be looking at having to do things like chemo and radiation. So how do we know if we should be concerned about a lesion in the skin, or a little bump or a mark or a black spot or anything like that? When we talk about skin cancer and just general skin observation, we talk about the A, B, C, D, E's of skin cancer. So A stands for asymmetry. Is the lesion or the mole, whatever it may be, is it nice and symmetrical? Can you draw a line down the middle of it and each side looks exactly the same? You are symmetrical. Neither of these lesions here are. The one on the bottom right, almost, but not really. The one on the top left kind of looks like Australia if you squint a little bit. B stands for border. Does it have a nice distinct border, or is that border kind of fading off into the skin? And we see a good example of that in this up here, especially like this section right here. You see how the border is kind of fading off into the skin, very different than at the bottom of that lesion. That's a cause for concern. B can also stand for bleeding. If you bump it or scratch it or knock it, does it bleed a lot more easily than the rest of the skin around it? That could be cause for concern as well. C stands for color. Whatever color it is, you just want it to be one, and you don't want it to be like a shiny dark blue-black, which is what we see in the bottom right. In the top left over here, like this thing is, all kinds of different colors. Actually, if you look at it, you can kind of pick out different seats in Australia. Like down here, this is New South Wales down here, and here's Victoria up here. There's Perth. This is Queensland. That's not good. We don't like moles or lesions that have lots of different colors. The D stands for diameter. You don't want it to be any further around in diameter than your pencil eraser. If it's getting bigger than that, please go see someone. And then E stands for evolving. If it's changing over time, it's changing color, it's changing shape, it's getting bigger, anything like that, that's also cause for concern. So that's how you would know if what you're looking at is something that might have problems or give you issues later on. All right, last of our skin cancer types is Kaposi sarcoma. This is a very rare cancer type. This is cancer actually of the blood cells that line the cells that line your arteries and veins. And that's what causes this kind of reddish, purplish lesion on the skin that you see with Kaposi sarcoma. You will never see Kaposi sarcoma in a healthy patient. You will only see this in a patient who is immunocompromised in one way or another. You see it a lot in patients who have AIDS. What does immunocompromised mean? Probably you've heard that word thrown around a lot when we're talking about coronavirus and we're talking about we have to protect the old and protect those who have been immunocompromised. So to be immunocompromised simply means your immune system is very, very weak for whatever reason. And there are a lot of things that can put a person into that position. This is not just, oh, I have a really bad immune system. I always get a cold every time it's cold and flu season. This is much more serious than that. So a patient who has AIDS, they've gotten to the point where the virus has knocked out their immune system and they're very, very susceptible to really simple infections. You see this, you can have a patient who's born without a functioning immune system. There's stuff like SCID, XLA, CVA. These are all genetic diseases in which your patient is born without the ability to make antibodies. They're born without a working immune system. Other things that will make a patient immunocompromised. Think about what we talked about with our autoimmune disorder patients. They needed to be on immunosuppressant medications. So your patient has, say, think about the picture of pemphigus that we saw, all the blisters all over his back. That patient's going to need to be on medications that will really, really turn down the immune system so that it's not working as hard. And that will increase your risk of picking up different diseases, including Kaposi sarcoma. You see this immunosuppressants in patients who have autoimmune disorders. You also see this in patients who have had organ transplants. If you had an organ transplant, we talked about Selena Gomez getting her new kidney, she's going to have to be on immunosuppressant medications for the rest of her life in case one day her immune system suddenly realizes, wait, that's not my kidney, and starts to attack and reject that kidney. Other things that will make a patient immunocompromised, if they are on chemo, that will significantly weaken the immune system. So all of these patients right here are at higher risk of getting Kaposi sarcoma. Again, you will never see this in a healthy patient. If you see this in a patient, something else has gone wrong. The reason why Kaposi sarcoma is so rough is because it metastasizes through the body very easily. And when it starts to metastasize through the body very easily, does your body really have the immune system to even fight off this cancer? No, your immune system is shot. So the cancer spreads very quickly and very fast through the body and quite often is lethal by the time that you develop it. We will talk a little more about HIV and AIDS next week when we get into our cardiovascular and blood type stuff. You hear this all the time, oh, he died from AIDS, he died from AIDS. My last class was really big onto Eazy-E for whatever reason, and I heard a lot about, oh, Eazy-E died from AIDS. Nobody dies from AIDS. It's not the virus itself. HIV does not kill you. It weakens you to the point where something like Kaposi sarcoma can come in and then finish you off. And Kaposi sarcoma is a very common cause of death in patients who have AIDS. You'll see on the death certificate it says died from AIDS-related causes, and then usually we'll say something like Kaposi sarcoma or pneumocystis pneumonia, which are very, very common causes of death in a patient with HIV. Again, we will talk more about HIV next week, so come with all of your pressing questions. Okay, last topic for this lecture. Thank you for hanging in there this long. This I think you're going to find very interesting because you probably have never heard of it before or seen it. Smallpox is a viral infection caused by the variola virus. This is not the same as chickenpox. Chickenpox is herpes zoster. Smallpox is variola. It has about a 30% fatality rate. So you and two of your best friends get smallpox, one of you dies. That's really high fatality rate, all things considered. There is also a very severe strain of smallpox that would cause hemorrhage as well. There's no cure for smallpox. And in its heyday back in 1967, you saw about 15 million cases of smallpox a year across the world. That's a lot of smallpox. It's spread by contacting the body fluids of an infected person, which is really easy because smallpox causes these pox-like lesions on the skin. And those pox-like lesions hold the virus. The virus is replicating in those little pustules. And when those pustules erupt, that releases fluid that has lots of virus in it, and then it's very easy to spread that from person to person. These pustules would lead to permanent scarring. This is not like chickenpox at all. You get permanent, very severe scarring. If you get these pustules in the ears or near the eyes, it can lead to blindness and deafness as well. It's a really, really nasty disease with some pretty severe long-term consequences. There is a vaccine for smallpox. This vaccine was developed in 1796 by Dr. Edward Jenner, the very first vaccine that we ever had. And the story behind it is wonderful. The story is that Dr. Jenner was a physician in England. And back during that time, it was very common to have kind of waves of a smallpox come through a community. The same way that we have flu season, they would have smallpox season, which is a significantly more terrifying season. And Dr. Jenner, in his practice, noticed that there were certain people who would not get smallpox when smallpox went through the community. And these people were dairymaids. They worked with cattle. They milked cattle all day. And his hypothesis was, since cows get a very similar disease called cowpox, maybe since these dairymaids are always around the cows and always exposed to the cowpox, maybe that prevents them from getting the smallpox, because when smallpox went through, these dairymaids would not get it, or they'd have like one or two little lesions and that would be it. They wouldn't be covered in pox like this person on the right. So Dr. Jenner, to test his hypothesis, went and got a neighbor kid and found a dairymaid who had a few little pustules on her hand from smallpox. There was a smallpox epidemic right now. He scraped the fluid out of the pustules on her hands, and then with a little needle, he pricked that fluid into the arm of the neighbor boy to see, will this protect him against this smallpox that's going around in the community? And what do you know? It worked. The kid did not get smallpox. He was perfectly safe during the outbreak, and this was where we discovered the idea of vaccination. And the word vaccine even is a nod to this discovery. For my Hispanophone students out there, how do you say cow in Espanol? Like cow is vaca, right? Or if you speak French, it's vache, une vache. So both vaca and vache come from our Latin word, vaca, which is where we get the word vaccine. It is a nod to the cowpox with which Dr. Jenner inoculated that boy. The smallpox vaccine is really, really effective. It's an excellent vaccine. And about 200 years later, in 1959, the Global Smallpox Eradication Program was developed. And the goal of this program was to eradicate smallpox, was to get everybody vaccinated for it so we could get rid of smallpox, because we have a really good vaccine, we have a really terrifying disease. Let's see what we can do about it. Prior to that, smallpox had been eliminated in North America and in Europe in the early 50s. The program really ramped up in 1967, and within 10 years, we saw our last case of smallpox in Somalia on the Horn of Africa in 1977. Here's Dr. Jenner injecting the neighbor kid. If you look up Dr. Edward Jenner, you'll see any variation of this picture. It's a very, very famous picture. This is our map showing the elimination of smallpox across the world with the Global Smallpox Eradication Program. Interestingly, Australia never had endemic smallpox, so they did not have the issues that they had. They didn't go through the program. So like you can see, North America and Europe, there was no more smallpox by the early 50s. In South America, we see the last known case in 71. In Asia, the last known case of smallpox in 75. And then the continent of Africa, the last known case in 77 was this case here in Somalia. Actually kind of a sad case. He was a vaccine worker who was working to inoculate children against smallpox. He contracted smallpox and he died from it. So that was our very last known case of smallpox ever. You can imagine this took a lot of work. Think about what it would take to coordinate people to do this. I mean, just today, it would be much simpler. We have the internet, we all have smartphones. It's very easy to get in contact with everyone. Imagine trying to do this in a world where there is no internet. You cannot jump on Gmail and hammer out an email requesting more vaccines or talking about how many cases of smallpox you found today. You could do international phone calls, but they were very, very expensive and usually the quality pretty poor. So it's very impressive that this was coordinated and pulled off long before there was any internet. Imagine trying to do something like this today, thinking about everything that we see with all of the madness and chaos and uncertainty going on with coronavirus and a potential coronavirus vaccine. So after that last case of smallpox in Somalia, the whole world went into a 2-year case finding period where the World Health Organization did a lot of very careful epidemiology, a lot of careful recording to see, does any other case of smallpox cropped up? And after 2 years, on the 26th of October in 1979, the World Health Organization declared smallpox 0 day. So 2 years, we have not found any more smallpox cases. There is no more smallpox in the world. That was 40 years ago. We still have not found a case of smallpox. So we're good. Smallpox has been eliminated, eradicated from the world. It is extinct in the wild. Now, that is not to say there is no more smallpox. Many governments and government laboratories have small samples of smallpox that they're hanging on to for research purposes, is what they claim. And there's always been small murmurings and concerns that one of those vials of smallpox could fall into the wrong hands and then be used as a biological weapon. And that is kind of a legitimate concern because nobody's vaccinated against smallpox anymore. None of you probably were. I was not. You only get the smallpox vaccine if you are working with the virus or if you're in very specific levels of the military. So we have a population, at least half of it, maybe more than half of it, has no immunity, natural or vaccine or otherwise, to smallpox. So that could be very concerning. Now, the US government swears up and down that it has enough vaccine in reserve stored up to vaccinate everybody if we were to have a smallpox outbreak. But again, imagine trying to get everyone in the country vaccinated. I mean, people are absolutely certain that they're going to have a radio chip stuck in them if they get the COVID vaccine, so I cannot imagine that the smallpox vaccine would go any better. Interestingly, the FDA recently approved a treatment, a cure for smallpox, the first one that we've ever had. So again, this is still kind of in the back of everybody's mind. But with that said, it's an interesting disease. It's a fascinating history. The only human disease that we have ever eliminated from the planet. We've wiped out one other disease that's called rinderpest. It's a disease that you find in cattle. It's kind of like measles in cattle. We're very, very close to eliminating a second human disease, would be the second one that we've ever wiped out on the world, and that is polio. Polio used to be very widespread, causes muscle weakness and paralysis, and really nasty post-polio syndrome. We will talk about it when we get to the nervous system, but we are very, very close, probably 10 years out from eliminating polio. You will probably see it in your lifetime. We have maybe 30 cases of polio a year, and most of them are in Pakistan and Afghanistan. So hopefully you will live to see that. That would be a fascinating thing to witness in history. I hope that you have learned something interesting through this presentation on the integumentary system. At the very least, I hope you're going to go put on some sunscreen. As always, if you have questions about anything on here, or if you would like to talk further about any of these topics, come visit me during office hours or send me an email and I would be happy to chat. Otherwise, thank you for stopping in.